Hello, good evening, doctors. How are you all? Welcome to another session of random MCQ discussion. Today is going to be the first class for all for the month of November. Uh, Let me see. Okay, so it's great to hear that you all are fine. I'm also doing good. Thank you for asking, Dr. Muhammad Walid and Dr. Midahat. All right, so let's start without further ado with the first question. This is the first question for today. I hope you can hear me and see the screen from the responses that you all have provided in the chat box. So I'm just proceeding. So we have an 8-year-old boy who was injured when he tried to intervene in a fight between his pet cat and dog. Which one is most appropriate use of antibiotics for this condition? A. Antibiotic prophylaxis depends upon the extent of the wound. B. Prophylactic antibiotics are recommended for all bites. C. Antibiotics are only indicated if infection is present. So what do you guys think is the correct answer here? A, B, or C? Okay, so let's see what you have thought. Okay, most of you think it's A, some for answer B. Okay, so this question tests your knowledge on management of animal bites. So I'm not sure whether I discussed with you all. I think I discussed about this topic of animal bites with the previous group of students. They had another question, I think, about a bat bite to a boy or something like that. Not this one, but here again, the question area that is being tested is your knowledge on management of animal bites. So for that, we have few references. First, let's go to that. So we have this by the RSEGP, Management of Mammalian Bites. Okay, so you should be very familiar with this. Okay, so what you have here, so they have discussed about different types of animal bites. Specifically, they have discussed about the microbes that can be transmitted via the animal bites also. And then the antibiotics in this table, since we have this here, I'll just say a word and go. So here you have not a table, actually, a box where they have indicated the antibiotics that could be used in two separate instances. One, infection not established, that is a prophylactic antibiotic, and the second one being infection being established. So the recommendation on whether to give antibiotics for everybody or for specific cases, I'll discuss it when I go through the next page. But for the time being, the recommended antibiotics, you have a box like this. I'll come back to this later. So you have different types of bites here. They have nicely discussed it, everything, monkey bite, rodent bite, etc., and the assessment is there. Then this is the most important part of this note. Actually, they have given how to manage such animal bites. So resuscitation part is there for any injury or any presentation. Then history, you have to take a good history. Examination, imaging, like if you suspect any foreign bodies, like a teeth of an animal. So likewise, then you have to do these steps in management. So wound culture, when clinically you have signs of clinical infection. Then wound management involves cleaning, irrigation, debridement, etc. Then wound closure if there's no contamination. Then elevation and immobilization during the first 48 to 72 hours. Then tetanus prophylaxis, you have a separate topic, tetanus administration of immunoglobulins, vaccines and all. I think I have discussed with you all. But here, in a brief sentence, tetanus toxoid should be administered if 5 years since the last dose and the patient has completed a full primary course of tetanus immunization. Then if unvaccinated, they should be given toxoid and immunoglobulin both. Then specific for bats, we are not going to discuss that. Then we'll come to the antibiotic part. So antibiotic, now it's a controversial topic, but the recommendation is you have to treat if there are signs of established infection. So if you see pus, if if the patient has fever, if you have pus discharge or signs of infection, then you are going to definitely treat. But even if you don't see signs of infection, you can give prophylactic antibiotics for patients who are at high risk. So we'll see who they are. But if you have, it's not patients actually, wounds which are high risk wounds, if you have wounds which are seem to be high risk wounds, then again you have to give antibiotics as prophylactic. Then patient education is there, patient review is there. So this is like the summary of this article. About this high risk group, I will let you all know what are the high risk groups. But before that, now I told you antibiotics can be given in established infection. I'm coming back to this box which I showed earlier. If established infection, we are usually going with the metronidazole plus either cefotaxime or ceftriaxone. If infection is not established, that means if we are giving prophylactically for a high risk group, then we are going to give amoxicillin and clavulanate. Okay, so now the high risk group, I'll show you that. Okay, now for let me take you to the high risk one. Okay, high risk wounds only. So it's not here actually. It was there in the RCH one. Okay, so that's it that you can find from this. But they have discussed about the high risk groups also. But specifically for children, I'm taking you to this reference. Same thing, but more detailed. Animal and human bites by RCH. Now, they have nicely classified what are the high risk wounds. Okay, so here it is. I'll just zoom it out. These are the high-risk features. So wounds undergoing primary closure, delayed presentation, deep puncture wounds or lacerations, bites on hands, feet, face, genital area, close proximity to a bone or joint, associated crush injury involving an open fracture, immunocompromised child, or cat bites. So these are like high-risk wounds which need prophylactic antibiotics. So this RCH article also they have nicely given like to how to evaluate and how to treat, but the principles are more or less same. So in a nutshell, like you have to do initial resuscitation, then you have to consider wound management, where you are going to irrigate and clean the wound, and you are deciding whether to close or not. Then you're going to consider tetanus prophylaxis, rabies prophylaxis. Again, you have to consider, especially in bat bites. Okay. Then you are going to consider antibiotics, whether if there's established infection, you're going to give antibiotics anyway, or else you're going to give prophylactic antibiotic only for high risk wounds. Okay. Okay. All right. So is it only for children? High risk? No, no. For any high risk wound, now if you see this high risk wound, not only for children, even for adults, these will apply. A wound close to a bone or joint is a high risk even for an adult. Okay, so these are wound characteristics actually. So even for adults, same things apply. In our RSEGP, they have not clearly mentioned the groups like nicely as here. So I have included both the links for you all to go through. Okay, so I don't see any other questions. So let's go to our MCQ. We have 8-year-old boy. Okay, so pet and dog. Most appropriate use for antibiotic for this condition. Antibiotic prophylaxis depends upon the extent of wound years. Prophylactic antibiotics are recommended for all bites. Wrong. Antibiotics are only indicated if infection is present. Wrong. So the correct answer here is answer A. Okay. So I hope it's clear to you all how to manage the animal bites. Let me see whether there are some more questions. Okay, Dr. Shamanti, high risk features I have showed previously as a list. Give me 1 second. Okay. Okay, so prophylactic antibiotics. So here answer. So let me go through the questions. Dr. Urmi, so cat and dog fight injury high risk? Yes, you are correct. High risk, I was asked answering Dr. Shamanti actually. So you have these features for high risk bites here. These are the features. Okay, wounds undergoing primary closure, delayed presentation, deep puncture wounds, cat bites, etc., etc. Okay, so I hope it's clear now. All right, so let's go to the next question now. So this is the next question. 37 weeks POA, sudden gush of fluid, now having greenish discharge from cervix. Cervix not open, no contractions, maternal and fetal vitals normal. What to do next? A. Prostaglandin 2, B. Oxytocin infusion, C. Cesarean section, D. Observe. What are you going to do here? Oh, sorry for that. I haven't unmuted myself. So sorry for that. So what I was telling was, now when you have a case, now this is a case of, okay, so this is a case of rupture of membranes, or this is a case of from pre-labor rupture of membranes. So when you have a case of dribbling or rupture of membranes, there are several steps that you have to take, or you have to you have to do to determine the answer. The first step would be determining whether the woman is at term or preterm, because the management will completely will be different if it's a term woman or whether it's a preterm woman. Now here it's a term woman because she's 37 weeks of POA. Now she's coming with sudden gush of fluid. Now she's having a greenish discharge from cervix. Okay, now first step I told was to determine whether the woman is at term or preterm. The second step would be to determine whether there are any high risk features or whether there are any impending problems in maternal side as well as in the fetal side. So in the fetal sides, you have to see whether there are any problems with the fetal heartbeat, whether there are any problems with the fetal CTG or anything as such. Maternal side, you have to check whether there are any maternal decompensations or maternal fever or any things like that. So because if you see any such problems, that will help you, that will make you, like, that is a high risk feature, that will be a very important thing that you should consider. The third thing you have to consider is to see whether the mother is in labor or not. Okay, because that will also determine your management. If the mother is in labor, you have to see whether the labor is progressing or whether it has arrested. If she is not in labor, you have to decide whether you are going to induce this woman or not. Okay, so those three will be like the basic steps. Now here you have a term woman. She's coming with this rupture of membranes. Now she's having a greenish discharge. What do you mean by this greenish discharge, Cancer? Okay, so you have already mentioned meconium. So you have already mentioned. So this greenish discharge is passage of meconium. from the cervix. Okay, so now you have a high risk feature here, not a very high risk, but you have something problematic because this baby has already passed meconium. Now see, the cervix is not open. So the third factor, whether she is in labor or not, cervix is not open, no contraction. So she is not in labor. Okay. Maternal and fetal vitals are normal. So now the problematic part, the greenish discharge or meconium is there, but both mother and fetus are stable because maternal fetal vitals are normal. Okay, so now we know this is a term patient. The mother and baby are fine. They are not unstable. But there is a high risk feature of this greenish discharge or passage of meconium, and she is currently not in labor because cervix is not open and no contractions also. Now you have to decide what you are going to do. Okay, so your decision will be only two decisions. One would be whether you are going to induce this woman for a labor, or whether you are going to observe this woman, or whether you are going to go for a cesarean section. So 3 steps. Okay, so after determining these 3, your decision would be whether to induce labor, whether to go for a cesarean section, or whether to observe and see. Okay, now here, for this, you need the knowledge of management of rupture of membranes. So I'll take you to that. Now, so you have this RENSO guideline on term pre-labor rupture of membranes, or term PROM. Now here, it's a very small guideline, only about 8 to 9 pages. Now here you see the recommendation. What they say is, let me take you to this. In women with ruptured, I'll zoom it, in women with ruptured membranes, at term, induction of labor within 24 hours is recommended. That's their recommendation. But they say you can go for expectant management in some, whether you are not going to go for a induction as such, but for you to go for expectant management, you have these criteria. Like in that means the mother or the baby should not have any problem if you are going to decide for an expectant management. The features would be fixed cephalic presentation, negative GBS, normal CTG, clear amniotic fluid, some things like this. Clear documented plan for review. This list. Now here you can see they have mentioned clear amniotic fluid. So if the amniotic fluid is clear, you can wait for expectant management. Now this baby, before going to our case, here they have given a nice account on the role of antibiotics. I'm not going to discuss. And that's it. It's a very short but a very good guideline on management of PROM. You have everything that you need to know about PROM management. So now let's go to our case. Here we have this problem, which is with the child has passed meconium, where you have a greenish discharge. Okay, but although the child has passed greenish discharge, so although the child has passed meconium, okay, the child is, the mother and the fetal vitals are normal. So you don't need to go rush and do a cesarean section here. Okay, so you are not going to select answer C because of that. Though meconium is there, still the baby and mother are stable, no problems. So you don't need to go and rush and do a cesarean section. But you are not going to do D also because you are not going to go for expectant management here. You have meconium. So you are going to induce this patient for labor. So the induction method, you are going to do, you have 2 answers, prostaglandin and oxytocin. Now here see, oxytocin we choose when the contractions are not adequate. But, or when you have good cervical ripening but no contractions, only you are going for oxytocin, just like an augmentation. But here the cervix is not open. Cervical ripening has not occurred. So here the next thing that you can do, best thing would be to go for prostaglandin, where you are going to ripen the cervix. This prostaglandin will ripen the cervix. Not only that, it will induce labor also. Okay. So the correct answer here would be answer A, which is prostaglandin. So the steps we took was, first we determine whether we are, first we determine, 1 minute. First, we decided whether we are going to go for induction of labor or not. And we decided that this is a high risk one. We are not going to go for expected management, but we don't need to rush for cesarean section also. So in the middle term, so we are going to induce. For that, we are going to select prostaglandin. So that's how we decide on the answer here. I hope it's clear to you. I took some time here because I didn't get a good opportunity to discuss the labor questions with you all in detail. Some of you had mentioned it to me previously, so I took some time to explain you how to approach a question of labor, because this labor and obstetric questions you have to work on your own. Those are not straight away theory. You need to know the art of solving those questions. Okay, so I hope it's very clear to you all how to approach this. Okay, ma'am, if CTG is the option, ma'am, if CTG is in the option, do we need to choose that? Yes. If CTG was here, you are going to choose CTG because you are going to decide whether the baby is healthy or not. But here now, they have given only the vitals. Maybe the CTG was also normal. But if you had an answer of CTG, you are going to choose that. Can't the fetus condition deteriorate if we wait? Now you put the prostaglandin, but that doesn't mean you're not going to do cesarean section at all. That doesn't mean like that. You have put the prostaglandin, you are continually monitoring the baby and the mother. At one point, if you see the baby starting to deteriorate, or if you see something is not doing well, then even though you have put prostaglandin, you can still go for a cesarean section if something goes wrong. Okay? So you are going to monitor. Now everything is stable. So now you are not going to rush for a cesarean, but anything can change in the middle. If it changes, you are going to decide for the next step. So you are not going to put the prostaglandin and go away. You are going to monitor the mother. If she deteriorates, you are going to change your decision. Okay, Dr. Faizia, oxytocin is given when the cervix is ripened. Dr. Sandra has mentioned, yes, when the cervix is ripened, you are going to give oxytocin. And if the contractions are not adequate also, you are going to give oxytocin. Okay? Did I answer? What's the route for prostaglandin? Thank you. Okay. Okay, I think I answered all the questions. Some of the questions have been answered by you all also. Okay, so now if this fetus condition, if they have mentioned the fetus is having some, if the CTG has deceleration, or if the fetus is showing some tachycardia or bradycardia, then you are not going to wait, you are going to go for a cesarean section. So it's a case by case decision. Dr. Tina, cervix. Not oral, you are going to put by cervix. Okay. Did I answer all the questions? I think I have answered all the questions. Okay, if you have any questions, you can put. There are a couple of labor questions. This time we'll discuss as we go on. Okay, see whether you can answer this. Refugee who just arrived in Australia took only oral polio vaccines at 2, 4, 6 months. Clinic only has injectables. What to do? This refugee has taken oral polio vaccines 2, 4, 6 months. A, no need of further vaccines. B, restart schedule with injectable vaccine. C, continue immunization with injectable vaccine. Okay. Let's see, what do you think here? Yes. Okay, I'm very happy to see that 2 of y'all have asked the age of the patients. It's very good. Okay, now here you can't mark an answer without knowing the age of this patient. Because a refugee, you don't know whether this is a child, you don't know whether this is an adult, or whether this is a baby, you don't know like the age. If you don't know the age, you can't come to an answer here. So I'm very happy to see that few of you even thought about the age. Okay, so now we can't select one answer here without the age. But that doesn't mean that we are going to skip this question, because this area is very important about this poliomyelitis and the vaccines. So let me discuss that with you all. So this is, now whenever I think I have told you previously also, whenever you have a problem with the vaccines, your reference would be the Australian Immunization Handbook, okay? So you have everything under the sun about vaccines in this book. So for poliomyelitis, You have a nice account, but I'm not going to discuss everything. The most important thing would be now usual recommended regime would be infants and children are recommended to receive 4 doses of IPV containing vaccine. So that's the recommendation. In the schedule, you have 2, 4, and 6 months of age. You have this polio vaccine, and then you have one at 4 years. So that's like the usual schedule. Now this refugee has taken a 2, 4, and 6 month. Now we don't know whether this is less than 4-year one or more than one. So because of that only I said without age we can't mark an answer. But here the problem here is not only that. Now here you have all the things, other things also. Now if there is a children who didn't take all 4, if there's a traveler, if healthcare worker, lab worker, everything is there nicely. You can go through it leisurely. In our case, the problem is not only about the age, but about this unavailability of oral polio vaccine, because this refugee has taken everything oral. Now in the clinic, you have only IV. So what does the vaccine recommendation say about that? It was here. Okay, where is it? Okay. Now here see, oral polio is no longer used in Australia, but oral polio and IPV are interchangeable. That means if the child has taken oral polio 3 vaccine, and if the next vaccine is due, you can give IPV instead of the oral polio vaccine. Both are interchangeable. So that's the important point that is being tested here. Okay, so now let's go to our question. Though we are unable to mark the answer, now this refugee took only oral polio vaccine. So no need of further vaccines. That's actually wrong. Now let's discuss this under 2 topic. If this refugee is less than 4 years or approaching 4 years or more than 4 years child, if it is a less than 4-year-old one or a 4-year-old one, you are going to give the 4-year-old one. You can give with the schedule with the injectable vaccine. Now, if it is an adult one who has missed the 4th dose, you can give not adult means a bigger child, you can give a catch-up dose with the IPV. Okay. Or if it is less than 4, your answer would be continue immunization with the injectable vaccine. So don't get confused. Here you can't mark an answer without the age. The take-home message is oral and IPV can be interchanged. And there are 4 vaccines that should be given, 2, 4, 6 months and 4 years in the schedule. So if somebody has taken only 3 and if the next is due, you have to give it with either oral or IPV. Okay, so that's the take-home message. You can't mark an answer here without the age. Okay, ma'am, please repeat. Okay, I'll repeat it again. Okay, so what I told was I'll take you all to this age thing, repeat. Okay, so you want the age thing. Okay, so now what I said was I'll come here. Now in the schedule, immunization schedule, for polio, the baby or any child in any Australian child should receive 4 polio-containing vaccines. 3 at 2, 4, and 6 months, and the 4th one at 4 years. Okay. So now suppose this refugee child is less than 4 years. If this child is a 3-year-old one, then he has taken 2, 4, 6 months, the 3 doses. His next vaccine is due on his age of 4 years. But here you don't have oral polio, so you can tell him to take the IPV at 4 years, if it is a less than 4-year one. Now suppose this child is more than 4 years, maybe 5 or 6 years, so he has missed a 4th dose. Then you have to give a catch-up dose because it is recommended in the guideline that I showed, giving a catch-up dose if they have missed 1 dose. That catch-up also you can give with an IPV. So if it's a 6-year-old who missed 1 dose, you can give 1 additional dose of IPV for this 6-year-old. Okay. So that's what I told, less than 4 and more than 4. Anyway, you are going to give 1. The timing is the one that depends. Did you understand? Okay, you have understood. Okay. So I hope it is clear for all of you. Clear. All right. Okay, so for this question, even if less than 4, we can continue. Yeah, for this question, the take-home message would be that there are 4 vaccines in the schedule. You need to know that. 2 for 6 months and 4 years, and then oral and IPV can be interchangeable. That's what you need to know. Okay, all right. So let's go to the next question then. Okay. 14-year-old girl came for HPV vaccine at school, but parents refused to give consent. What to do? Okay, so here most of you have thought of answer A, which is giving the vaccine. A, Gillick competence. Okay, so I'm happy to see that all of you, most of you have understood the principle of Gillick competency. I think I discussed about with you all previously also. So this is a 14-year-old girl. Now we can consider her as a mature minor. We need further information, but it would be given to you in your exams. Let's consider her as a mature minor. She came for HPV vaccine at school. Though the parents has refused, under the Gillick competence, you can give her the vaccine. So the correct answer that you can choose would be answer A. You don't need to ask her to bring the parent. You don't need to ring the parents and get consent. You don't need to consider the community center. So answer would be answer A. So this, I think all of you are very familiar with this concept of Gillick competency by now because I discussed it with you all previously also. And I shared this with you all, the link in the previous class. For those of you who didn't join that class or didn't go through that, I'll link it in this class also. You can leisurely go through this and read this and understand. But Gillick competence, I think all of you know. If you have any questions, you can ask. Okay. So I'm not going. Okay, Dr. Noor, could you explain briefly? Okay. The thing is, okay, please repeat again. All right. So I'll take you to that. So this is the reference. So now whenever you have a minor, okay, can somebody mention who are minors? The age cutoff? Yes. Correct. So here you have it actually. So you have, usually we consider less than 15 as a child. For young person, less than, if it is a less than 18, actually we can, more than 18 are the ones we consider as adult. Others are not adults, but less than 15 is a child, okay? Less than 8, more than 18 is an adult. But even less than 18, we can categorize as child and young person. Young person is 16 or 17, child is less than 15. Whatever it is, all are minors. So this minors, ideally, now whenever you have a procedure, when you're going to do something, you have to take the consent from the patient. So if it is an adult, no problem, you can take the consent without any problem. But if it is a minor, less than 18 years, we have a principle known as Gillick competence. That means we consider, now if the minor has the capacity to understand what you are telling, and if the minor has the capacity to understand what you are telling, and if they are capable of giving the consent independently, then we consider them as mature minors. Okay, there are criteria that need to fulfill. That means you have to show that this minor is capable of understanding what I am telling, and he can independently take a decision. If that minor is capable of that, then you can take the consent of that minor as a valid consent. For example, a child can, if this child, this one who is asking for vaccine, can understands what is the HPV virus and what does it cause and what is the risk and what is the importance of taking the vaccine, even though the parents say, no, we don't want the vaccine for the child, you can still give the vaccine to the child. But suppose if this child doesn't understand a thing about HPV and this child is not understanding anything about the HPV or unable to give the informed consent, then you can't consider it as a mature minor. Then you can't apply the Gillick competency there. So Gillick competency is if you can show that the child is independently capable of understanding what you are telling and to give consent, you can take the child's consent as the legal consent. Okay, so that's like a summary. So that is a mature minors. In this guideline you have everything, like when to consider mature minor treatment, when to give them the consent, when can you use it, emergency treatment and everything, because it will take a lot of time, and I have also already previously described this, so I'm not going to describe in detail, but that's the summary for those of you who asked. Is it clear? Okay. So here we'll consider it as a mature minor, but we need further details, obviously, and we are going to give the vaccine. Okay. Let's go to the next question. 35-year-old woman had cervical screening at your clinic 1 year ago, which was reported as low-grade squamous intraepithelial lesion or LCL. You repeat the test after 12 months, reporting the same result. Which one of the following would be the next best step in management? A. Refer for colposcopy. B. Repeat the cervical screening in 12 months again. C. Perform cervical screening every 3 months. 4. Advise the patient for safe sex practices to reduce the risk of cervical cancer. E. No action is required. What are you going to do? Okay, so here this test, this is actually a bit old one. I think that I know this is not very clear, but still, I hope you are familiar with this. Cervical screening party, are you all familiar with this flow chart? I don't think I need to explain this. Yes, no? So I don't need to explain it. So that's good, because then it will save us some time to discuss some more questions. So here, now, since you all are very familiar with this, now let me see. Yes, okay. So nobody needs this to be explained again. So here you have this woman. She has had a screening 1 year ago, which came as LCL. You repeat the test after 12 months, again it's LCL. So what's the next management? You have to go by the flow chart actually. So she belongs to this category where it was LCL. Then they have repeated, but they have not mentioned anything about this HPV RNA. So let's assume that it was done and detected, not detected. We don't know. Actually, this question is lacking information. But let's go by only by this LCL part. Repeat HPV test in 12 months, HPV detected or not, we don't know whether they did the repeat and whether HPV detected or not. But even let's assume it was detected because it's LCL. So now again it's LCL. Now what you have to do, you have to repeat the HPV test in another 12 months. But the thing is, we don't know whether HPV was detected or not detected. If HPV was not detected, actually it can't be LCL. So we are assuming that HPV was detected and it is LCL. Okay, then you are going to go for a repeat HPV test in 12 months. Okay. Okay. So you are going to repeat it for the third time HPV test. So I'm not going to explain it in detail because you all are very familiar. So you are not going to refer colposcopy at this point. You are going to repeat cervical screening in 12 months again. No need to perform for every 3 months. Advise patient safe practice reduce the cervical cancer. No action is required. Okay, so answer would be answer B. Okay, since it's a very familiar area, I didn't describe it in detail, but if anybody is not clear, please let me know. All right. Okay. Now this question. See whether you can answer this. A female patient with osteoporosis and renal GFR 20 presented with fall and fracture. What to give for her condition? A. Alendronate, B. Denosumab, C. Teriparatide, D. Vitamin D, E. Strontium granulate. Okay, so this question tests your knowledge on management of osteoporosis. I discussed about osteoporosis management with you all, but here the additional information that is given is this GFR. See, the GFR is 20. Okay, GFR is 20. So that's the additional information that you have. Okay, now let's go to the management of osteoporosis. Now I discussed about this with you all previously also. Osteoporosis, pharmacological prevention and management. So here we discussed about the drugs and we previously discussed that the bisphosphonates are the first line agent. But the problem with the bisphosphonates are that you can't give bisphosphonate in renal impairment, specifically creatinine clearance is less than 35. Then we discussed about the other drugs also. But here I'll take you to the section. Now I'm not going to discuss this again. We have raloxifene, strontium granulate. I discussed about everything in detail in one of your previous classes. So now we are going to this section, special consideration when you have renal impairment. Okay. So when you have renal impairment, the thing is, as I told earlier, bisphosphonates are, I'll zoom this out. Okay, now I hope you can see bisphosphonates are excreted mainly unchanged via kidneys. So they should not be used if the eGFR is less than 30. And what about the other drugs? Strontium granulate and teriparatide are also not recommended if the eGFR is less than 30. Raloxifene, no problem, because it undergoes hepatic metabolism and it is excreted in feces. So you can use even in renal impairment. Denosumab also you can use even in renal impairment, no problem with that. So raloxifene and denosumab are the good ones for renal impaired patients that you can use. Okay, so let's check. So let's go to the question. In our question, we have alendronate, denosumab, teriparatide, vitamin D, and strontium granulate. Now we already discussed we can't use alendronate, we can't use teriparatide, we can't use strontium granulate, no point of using vitamin D alone. So the correct answer here would be going for denosumab, answer B. Answer B is the correct answer. Okay. All right. So let's go to the next question. 38-year-old female, 39-week POA, BMI 32, complained of reduced fetal movements for 24 hours. Heart rate, fetal Doppler heart rate 142, appropriate management. A, admit to maternal unit. B, tell high BMI, so can't feel fetal movement properly. C, CTG. D, obs referral. What are you going to do? Okay. So this question tests your knowledge on management of reduced fetal movement. Okay. So this is also very commonly tested area where it's a very important area as well, because if the mother complains of a reduced fetal movement, that's an important concern. So you have a 38-year-old female here. Now POI is 39. Her BMI is 32. She has complained of reduced fetal movements. Okay. But see, the fetal Doppler has detected a heart rate of 142. What is the appropriate management? A, admit to maternal unit. Okay, so now here, did anybody choose answer B? Nobody chose answer. There were a few. No, not few. Nobody chose answer B. Okay. So answer B is out here. Why? Because if the BMI is high, she would have not felt the fetal movement from the initial parts itself. Now she has previously felt. That's why she's coming with the complaint of not feeling fetal movements now. So answer B is out. Now, whenever you have a patient coming like this with complaint of reduced fetal movement, what they have done is they have done a fetal Doppler. That is to see whether the fetus is alive or not. The fetal Doppler will tell you, give you an instant at point heart rate. It will tell whether the fetus is alive or not. But that will not tell you whether the fetus is at risk, or whether there's any risk factor, whether there's any impending fetal problem that is occurring. It will tell only whether the fetus is alive or not. So you can't go only by the fetal Doppler and send her home. So the best thing that will tell whether the fetus is at risk or whether there's any fetal compromise that is being occurring would be to do a CTG. Now, she has complained of no fetal movement, but the fetus is live, heart rate is there. So you're going to check the fetus is doing okay or not by doing a CTG. So the next step would be doing a CTG. If the CTG is normal, yes, then you can reassure her and observe or send her if no issue at all. But if it is problematic, then you have to admit her, do obstetrical and everything. Okay, so the next appropriate management would be doing a CTG. Answer C. Very good. Okay. So next one. See whether you can answer this. An easy one. A 35-year-old woman presents to your practice with complaint of decreased ability to hold small objects between his thumb and index finger. He noticed it few months ago when he was unable to properly hold the door or car keys. Which one of the following conditions could have led to this presentation? A, radial nerve injury. B, carpal tunnel syndrome. C, anterior introosseous nerve injury. D, ulnar nerve injury. E, posterior introosseous nerve injury. It's a very... Okay, so here I can see most of you have answered answer C, which is anterior introosseous nerve injury. So anterior introosseous nerve is a branch of which nerve? Can somebody mention? Median. Okay, so it's a branch of median nerve. All right. So now you have a 35-year-old woman. She's coming with the problem of unable to hold small object with thumb and index finger. So there's a problem with opposition of the thumb. So thumb opposition, no okay sign is, okay movement is the one which is missing. He noticed it few months ago when he was unable to properly hold the card. Okay, now anterior interosseous nerve is a median nerve. So this can't be a radial nerve injury. So carpal tunnel syndrome, again a median nerve injury. Anterior interosseous nerve, yes, it can explain this. Ulnar nerve, wrong. Posterior interosseous, no. So how do you differentiate between B and C? Can somebody mention? Because even in a median nerve injury, you can get this, right? Because anterior interosseous is a branch of median nerve. Okay, so how do you differentiate? Can somebody mention whether it's B or C? Whether it's a carpal tunnel, how do you say this is C and not B, or B and not C? Yes, very good. Very correct. So in carpal tunnel syndrome, you don't get only this. Now they have not actually mentioned about any sensory feature here. Okay. Uh, Sensory they have not mentioned. So we'll assume there's no sensory impairment because it's not mentioned. And they have not mentioned any problem of the other muscles or the other muscles supplied by the median nerve. Only this particular movement of thumb and index finger they have mentioned. Okay. They have not mentioned anything about the other muscles that is being supplied by the median nerve. So because of that, you can't say that this is, so we'll assume the other muscles are normal. So because of that fact only, we are saying this can't be carpal tunnel, but it is an isolated anterior interosseous nerve injury. So the answer C is the correct one because they have mentioned only about this single muscle group or this opposition movement only. So it's only solely a motor problem, and anterior interosseous nerve is the one which supplies the motor part in the motor median nerve. So because of that, we are going with answer C. So if you had any confusion between whether it's a carpal tunnel or not, now carpal tunnel, you have other muscle involvement and other symptoms and the sensory signs, not sensory, other small muscles, other involvement is there. You will have a sort of a sleeping hand-like thing that is happening. So that is not here. All right. So the answer is answer C. I hope it's very clear and it's a very good question that tests your knowledge. Okay, so we'll do this question and then we'll have a break. Nurse had a needle prick of a drug rehabilitating man. Nurse had hepatitis B vaccine and positive serology 10 years ago. Man HIV negative, HBs antigen positive, HBe positive, hepatitis C RNA positive. What next management for nurse after taking serology? A. Check for Hep C in 3 months. B. Give Hep B immunoglobulin. C. Start retroviral drugs for HIV. D. Give prophylaxis for Hep C with viral drugs. What are you going to do? Okay, so now this question tests your knowledge on management of needle prick injuries, hepatitis C, B, E, and everything. Ma'am, answer it. I got it. Okay. All right. So now let's go to this reference. I think I discussed. Did I discuss about needle exposure, this guideline with you all, or is it with the previous group? I can't remember whether it was with you all or previous. Was it with you all that I discussed about this needle prick injury? No, not you all. Okay. So you have this guideline by the Australian prescriber that tells you the management of needle stick injuries in the primary care. Okay, so I'll just give you the summary. Now, what they say is, first for hepatitis B, let's see. In hepatitis B, what they say is when first you have the source and the now source is the patient and you are the one who got, like, let's say the needle prick injury. If the person who got pricked is vaccinated or immunized, and if there's a positive seroconversion being documented, then you don't need to do any further action. Okay, if immunized and vaccinated and not positive seroconversion is documented, no need to do anything. Okay. But whatever it is, you are going to anyway take the serum of the patient. So when you have the needle prick injury, first thing to do would be to check the patient status. That is by testing the patient or patient's serology. While the test is being ready, if you are immunized, then you don't, and if seroconversion is documented, you don't need to worry. You don't need to do anything. Okay. But if you are immunized, but there's no seroconversion, that means there's no documented levels of adequate antibodies, then you have to give a booster dose of hepatitis B vaccine. Okay. If that is given, if you can't measure the surface antibodies within the 72 hours. Okay, sorry. I think I confused you all. So, okay, so now if you have a needle prick injury, first you are determining the source or the patient. The patients, you are going to take blood or the serum of the patient to check for hepatitis B, HIV, and everything that you are going to test. Now, that will take some time for the lab report to come. In the meantime, if you are vaccinated and if you have documented level of antibody levels, you don't need to worry. You're not going to get hepatitis B immunoglobulin, no any vaccine. But if you are immunized, but no levels of antibody are documented or no seroconversion, then immediately a booster dose of hepatitis B vaccine should be given. Now, that is what you are going to do with the vaccine. But suppose the report that you sent for the patient takes a lot of time to come back, or it will take, it's not immediately available, then if your antibody levels were not previously documented, you are going to give immunoglobulin also. So if you are vaccinated and if your antibody levels are documented, or if seroconversion was documented, you are not going to give vaccine or immunoglobulin. But if you are vaccinated, but the antibody levels are not documented, you are going to anyway get a booster vaccine. You are going to get immunoglobulin only if that patient's report is getting delayed. Okay, that's the summary if you are vaccinated. But if you are not vaccinated, what you are going to do, then if the patient is at, now see here, if the person is negative, you don't need to worry. But if the person's result is getting delayed, then if you are not vaccinated, then you are going to get an immunoglobulin as soon as possible, as well as a vaccine. Okay. So that's what you have to do if you are not vaccinated. Then for hepatitis C, you are not going to give routine pre-exposure prophylaxis because routine vaccination is not necessary. If you have positivity, you are going to treat. HIV again is a dilemma because HIV drugs, they carry high risk of side effects. So you are not going to routinely give antiretroviral prophylaxis to everybody. That is what the guidelines say. Okay. So empiric post-exposure prophylaxis for HIV should be given only if you don't get the patient's result promptly. If you don't get the patient's result soon, then you can give the empirical HIV prophylaxis. You are not going to give empirical HIV prophylaxis for everybody. Okay, so even that is a case-by-case decision decided on a senior level. Syphilis again, not routinely, but if you have positivity in the patient. Okay, so that's like a summary. Okay, so did you understand that before we moving on to the next part? Any questions on that? Okay, so you didn't understand. So the thing is, remember it like this. HIV, you're not going to give prophylaxis for everybody. Give me 1 second. HIV, you are not going to prophylaxis for everybody because okay, so HIV, you are not going to give prophylaxis for everybody because the antiretroviral drugs carry high side effects. So you're not going to give to everyone. You're going to give antiretroviral prophylaxis only if the patient's report is not available soon because you are and the patient is a high risk one. In other cases, it's a senior level decision and you're not going to give routine prophylaxis. The reason is the side effects of the drugs. The next is hepatitis C, routinely not tested and routinely prophylaxis is not necessary. The next is the hepatitis B. So hepatitis B, you are going to anyway send the patient's serum for testing. And now it will take some time. If it is immediately available and if the patient is negative, you don't need to worry at all. But if it is not immediately available, then you are at a problem because it will take some time. Then you have to decide whether you are vaccinated or not. If you are vaccinated, then you don't need to worry. Why? Because unvaccinated, then you have to check whether you have documented antibody levels. So seroconversion is there or not. If seroconversion is there, means you have adequate antibody levels. In that case, you don't need to take antivirus vaccine, no immunoglobulin, no anything. But if you are vaccinated and the seroconversion was not documented or no antibody levels, then you are going to anyway take a booster dose of vaccine. But immunoglobulin you are taking only if the patient's report is getting delayed because if the report is soon available, if the patient is negative, you don't need to take the immunoglobulin. If positive, you are taking the immunoglobulin. Likewise. Okay, now did you get it now? Yes, okay. So you understood it now. Okay, thank God. All right. So now let's go to our question. Now they have done the tests. Now they have done, this is a drug rehabilitating man. So they have done all the tests. And this man is HIV negative, hepatitis B surface antigen positive, E positive, C RNA positive. What next management for nurse after taking the serology? Now, this nurse had the hepatitis B vaccine and the positive serology was also there. So, you don't need to give her hepatitis B immunoglobulin no vaccine. Now, HIV negative. So, you don't need to give HIV drugs, antiretroviral drugs also. Hepatitis E, you are not going to give anything because it's self-limiting. But the problem here is she has hepatitis C RNA positivity. So what does that mean? So let me tell you the interpretation of this hepatitis C reports. Okay, so this. So if you have hepatitis C RNA positive mean there's a current hepatitis C infection being going on. See, HCV RNA detected current HCV infection going on. Okay, if you have only antibody in hepatitis C, it's not a current infection. If RNA is not there, RNA is the one which tells whether current infection is going on or not. So this patient has a current hepatitis C RNA, hepatitis C infection going on. Okay, so you have to treat or you have to give prophylaxis for that because his hepatitis C RNA is positive. So you are not going to check hepatitis C in 3 months. You are not going to give hepatitis B immunoglobulin. You are going. Okay, so the answer would be answer D. Okay, because the C is positive. All right. Now this is an exception case because we have the hepatitis C RNA report available. If you don't have the hepatitis C RNA report available, we are not going to routinely give prophylaxis for hepatitis C RNA because the risk of transmission is very low. But because this patient has active infection, you are not going to ignore it here. So because of that, you are going to select answer D here. It's an exception case. Okay, did you get it? Why not B? Not B because the patient was immunized. Okay, did you understand it? Because the patient is immunized, you are not going to give vaccine or immunoglobulin. Now the level years, okay, but it is 10 years. Okay, it's 10 years, so that I'll show you. So the level of protection, I'll show you this evidence. So here, so this is again from the vaccine travel vax, which is also a nice site for vaccination tips. Now how long does the hepatitis B vaccination last? It remains intact for at least 30 years in healthy people who had the vaccination. So 10 years, no problem. Okay. All right. Is it clear? So any more questions on that? Uh, is it clear? Okay. So shall we have the break now? Let's have a break now for 10 minutes and we'll meet after the break. Okay. Okay, shall we start? Okay, there had been a long discussion going on. Okay, I think it's a discussion among y'all. All right. So see whether you can answer this. Son failed exam, saying will kill examiner. I am a brilliant student. They set up question to fail me. What in history will help to make a diagnosis? A, decrease in school performance. B, lack of sleep. C, delusion only. D, flight of ideas. C, hyperactivity. Okay, so some of you think it's answer A, some for answer D. Some for answer C. Okay. Okay, so what is the working diagnosis here? Can somebody mention what's your working diagnosis here? I agree this question lacks a lot of information, but even with the one that you have, yes, Dr. Chandima, bipolar, which component? Mania. Yes, very good. So this working diagnosis here seems like a mania, right? See, son failed exam, which tells you that it is affecting his school performance. Saying will kill examiner. I am a brilliant student. They set up questions to fail me. So what does this mean? I am a brilliant student. They set up question to fail me. What does it mean? Sort of a grandiose delusion, right? It's a grandiose delusion. He thinks he can do everything and he is a brilliant one. The others are doing things to fail him, and he's like very talented. So seems like a grandiose delusion. What in history will help to make a diagnosis? So this asks. So whenever you have a question asking what in the history or examination will help to make a diagnosis, then it should be the answer you select should be very specific, if possible, pathognomonic for that particular symptom, syndrome or particular diagnosis. If you can't find a pathognomonic one, at least a specific one is the one that they are looking for. Because if not, you can't, if you are selecting an answer which is valid for anything, you can't make a diagnosis actually. For example, see this answer A, decreasing school performance. Now it's already mentioned in the question, but even if it is not mentioned, decreasing in school performance will not help you to come to a diagnosis per se. It will tell you the impact of that disease to that person. Now, lack of sleep again is very non-specific. Delusion only is helpful because then it will tell you that it is a delusional disorder. If no hallucination means it's unlikely to be a schizophrenia or some sort of a psychotic disorder. So it's a bit valid. Flight of ideas, yes. Hyperactivity, again, is a specific symptom which you see in ADHD. But hyperactivity is not valid. So these A and B are not specific symptoms. So they are anyway out. They are vague ones. Out of C, D, E, hyperactivity is not valid here because you are not suspecting any sort of ADHD here. Now, delusion only and flight of ideas. So we are assuming a diagnosis of manic component or mania of a bipolar disorder. For that, a flight of ideas would be the one which if present, will help you to make the diagnosis clearly. For example, now this is the DSM-5 criteria for a bipolar disorder. Okay, so you need to have for bipolar disorder, you have different criteria of like how many manic episodes and how many depressive episodes and so on. I have not included them. What I wanted to show was this manic episode features. So in manic episode, you have this persistently elevated mood. With that, you have this inflated self-esteem and grandiosity, which is present in this person. Decreased need for sleep, more talkative than usual. Flight of ideas are subject to experience of thought are racing, which is there in the answer. Distractibility, increasing goal-directed activity, excessive involvement in activities that have high potential or for painful consequences. So if you have three of these, they have asked for during this period of this high mood or elevated mode, plus three or more of the following. So if you have flight of ideas, that is 2 out of 3. Okay. So because of that, we are selecting answer D, which is flight of ideas. Now, delusion only we are not selecting here because we are not thinking of a delusional disorder here. Okay. And even if we are thinking of a delusional disorder, delusion only will not help to make a diagnosis. So something that will help to make a diagnosis should be something very specific. Okay. All right. Hyperactivity is there in mania. Yes, it is there. A bit of component is there, but it's not a hyperactivity. That is worded as this excessive involvement in activities. Yeah, it's not a hyperactivity means not the hyperactivity we see in ADHD. Okay, so this hyperactive means that ADHD one. Yes, that's a goal-directed activities. Yes, very good. That's the reason. Okay, any more questions on that? Did you understand, Dr. Sidra, why we are not selecting hyperactivity? Now, in mania, you have increased involvement in the activities, but not the hyperactivity per se. They are like for a specific purpose, they are doing that. This hyperactivity is the one that we see in ADHD. Okay, so now here the thing is you have only 2 lines in this question. So you can't make a diagnosis as per se here actually. Now mania also we were thinking as a working diagnosis. This could even be a persistent delusional disorder. We don't know. But they are asking what will help to make a diagnosis. So in that case, the clue would or the trick would be to check, select the answer that is very specific for a disorder which will also fit for the presentation. So that's why we are selecting answer D. But this could be anything, even borderline. Sometimes it could be like that, but you will have more information for that. Okay. So don't think of the answer. Understand the take home message here. When you have such question, always try to select the answer which is specific for a disorder, which will help to make a diagnosis and which will also explain the presenting complaint. Okay. Hope it's clear now. Okay, no more questions. Let's move on. Woman with 6-week amenorrhea presented with low abdominal pain, vaginal bleeding, most appropriate test to do. A quantitative beta HCG, B TBS. It's a very easy one. I hope all of you will answer correctly. Okay, so all of you has answered answer A. Very correct. So I don't think it needs more explanation. It doesn't need to be quantitative even. Even if it's a beta HCG, that's correct. Because this is a 6-week amenorrhea. Woman with 6 weeks amenorrhea coming with low abdominal pain. The first thing you have to do would be to confirm the pregnancy here. Low abdominal pain and vaginal bleeding. This could be a miscarriage, or this could be even an ectopic. This could be anything. So it could be something unrelevant to the pregnancy as well. We don't know. But vaginal bleeding, mostly it's a miscarriage or ectopic or anything as such. But the first step here would be, we know 6-week amenorrhea only. We don't know whether she's pregnant or not or anything. So first step would be establishing pregnancy. For that, we need a beta HCG. But quantitative beta HCG even more better, because it will help us to find the cause also. So the answer would be answer A, like all of you have correctly mentioned. Okay, let's quickly move on the next one. 5-year-old boy was brought in emergency after rescue from drowning. Jellyfish is attached to his legs. He is screaming due to pain. What is your next step before removing tentacles of jellyfish? A, vaccination. B, IV morphine. C, anesthesia. Okay, so all of you have chosen answer B, which is IV morphine. So the jellyfish management, are you all familiar with that? Not jellyfish management, jellyfish sting management. No. Okay, so no. Surprisingly, no. I thought you would have had come across questions on this. No. Okay, all right. So let's discuss. Okay, so for jellyfish sting, you have this. So this is again from RSCGP, marine envenomations. So now when it comes to animal bites, not bites actually, stings, so animal bites and stings, mammalian bite is one common area which we discussed earlier. The next thing would be a spider bite. I think you all have come across a lot of questions on that spider bite, especially redback spider. The next thing would be the jellyfish sting. Okay, so jellyfish sting are also sting is very common here. So it's tested commonly as well. So when it comes to now, this account gives you a nice treatment on right account on different types of jellyfish stings, and also these fishes as well, stingrays, sea urchins, sponges, and all those other fishes as well. Now this other venomous fish, stingrays, sea urchins, sponges, you have a nice table like this. Going through this table would be more than enough, but it's not very commonly tested area. But jellyfish, yes. So for jellyfish, this table is like the gold standard. If you know this, like you know everything. So some sort of a thing like that. So when it comes to jellyfish, you have two types: linear tentacle-like sting and the Irukandji-like sting. Okay. So this linear tentacle-like sting is by this blue bottle and minor jellyfish or major box jellyfish. Now, Irukandji is by other box jellyfish. Now, why are we differentiating like this? Because the presentation as well as the management is different to different types of jellyfish. Now, in blue bottle or minor jellyfish, you will have immediate local intense pain for 1 to 2 hours, and you have associated linear erythematous eruptions. In major box jellyfish, you have severe local pain and erythematous eruption along the lines of tentacle contact. And even cardiovascular collapse can be there. In Irukandji syndrome, it's a delayed one. It has severe pain and systemic effects like tachycardia, agitation, hypertension, all those things, which is not there in other two. Now, the difference is the first state. Now, when you have blue bottle jellyfish sting, you have to wash the sting site with seawater. You have to do hot water immersion. You are not going to use vinegar here. So that's the commonly tested area actually. But for major box jellyfish and for other or the Irukandji like ones, you are not going to put hot water, but you are going to put vinegar. So that's the difference. So vinegar for these two, no vinegar for blue bottle and minor, only hot water. Then for this blue bottle and minor, no further intervention is actually needed. But for this major box jellyfish and other box, you have to give analgesia and you have to consider antivenom if there's a cardiovascular issue, and you have to transport if necessary. So that's like the summary of jellyfish sting management. Okay. So did you understand? Okay, that's like the summary of jellyfish sting management. You should know that. The only most important thing is when to put vinegar and when to put to hot water. Now here this boy uh, has jellyfish. So like management would be first removing the tentacles and then putting in hot water or vinegar depending on the jellyfish type. And you have to give other things like pain management and everything. Now here this boy jellyfish is still attached to his legs. You have to actually remove it. He's screaming due to pain. Now this is the leading one. This boy 5-year old, he's screaming in pain. What is your next step before removing tentacles of the jellyfish? So they have guided you, see. So sometimes you might think, now I have come across some questions from you all asking, now here if I select IV morphine, they will ask what if removing tentacles was there in the option? What are we going to do first? Removing the tentacle or treating the pain? So that's why I told you, you don't need to worry like that. Now they will lead you. He's screaming due to pain. What is your next step before removing tentacles? So that tells you that removing tentacles is important, but before that, what are you going to do? So you don't need to worry about removing tentacles here. Here the leading word would be screaming due to pain. So you have to address this. So you are not going to vaccinate. You don't need to anesthetize. You can give pain relief, which would be your IV morphine. Okay. In the meantime, you have to do the other thing. But in the clinical setup, you are not going to do one first and the next one like this. Everything would be done simultaneously. Okay. Okay. So let's see. Any questions? Okay, let me open the chat box. Okay, what other marine information important we need to go through from this guideline? If you know the jellyfish sting, that's more than enough. The other marine envenomations are not very commonly tested, but just have an idea for the sake of like betterment. No need to like go into deep. I can pick a right information that webs. Ma'am, if you give morphine after drowning, is there a chance for respiratory depression? Okay, now that's a very good question, Dr. Sneha. Uh, Morphine after drowning, is there a chance for respiratory depression? Now, that's a very common misconception and very common fear of not giving adequate pain relief. Now, when you go through this essential pain, I don't know whether you've heard about essential pain management guideline or course, so EPM, where they stress it's by the some anesthesiologist college or somewhere. So what they stress is they stress enough on pain management because they have found that the patients are not given adequate pain relief, especially in surgical setup and those things. And they have actually given a statement saying one of the most commonest reason for inadequate pain relief would be not using morphine because of the fear of respiratory depression. But that's not so. For morphine to cause a respiratory depression, there are several other cofactors, and it should be given in a very high toxic dose. A small dose of morphine for a pain relief will not cause respiratory depression, but the pain itself will cause more worsening problems than that worry. Okay, so you don't need to worry about that here. You can give morphine here. But your question is a very good one. Okay. No more questions. Let's move on. 1-month-old baby comes with purulent eye discharge. There was mild eye redness. What is the causative organism? A. Chlamydia, B. Gonorrhea, C. Streptococcal. If you can tell how do you differentiate in one sentence also, that would be great. But if you can't, that's all right. Just put the answer. I'll tell you how to differentiate. Okay. So here, okay, very good. You all have already spotted it. So what is this condition? What is the group or cluster known as? Do you know what is the name here? Okay. What is this clinical condition? Very good, Dr. Sandra. Ophthalmia neonatarum. Okay, so let me take you to the reference. So this ophthalmia neonatorum is a type of conjunctivitis that is happening in a neonatal period. So that's the ophthalmia neonatarum. Okay, you can, this is a bit lengthy one, but a very good one. So I will take you to the course. Okay, so where are the courses? Okay, so etiology. So this etiology, common ones would be your chlamydia and your gonorrhea. Then other viral infection, bacteria and GI tract infections can also cause. Okay, so when it comes to the non-sexually transmitted bacteria, you have your staphylococcus, streptococcus, gram-negative bacteria, Haemophilus, etc. Okay, so how do you differentiate? The differentiation, I saw one few of the doctors have correctly mentioned, is by the timing and the onset. So you have to do a complete history and physical examination and everything. Now, timing and the characteristic of clinical presentation are the one that will help you to differentiate. Okay, so now chlamydia and Neisseria, they are transmitted as, they are STDs. I think all of you know that. So timing means, now chemical conjunctivitis is something, we'll keep it aside, that usually happens within first 24 hours, but we are not considering chemical here. So gonococcal one usually happens in first 2 to 5 days. Now here the hallmark one would be a thick purulent eye discharge with remarkable chemosis and eyelid edema. But on the other hand, chlamydia one, you will have it after 5 to 14 days after birth. So after 5 to 14 days after birth. That means a bit later. So gonorrhea is early onset. But here usually bilateral or can be unilateral also. Here the eye discharge is copious initially, then purulent, and it is also associated with eyelid swelling. Now, herpes one is very uncommon. The other bacteria ones are also very uncommon. So, you are going to go by history and examination. Okay. So, they have mentioned how to treat and everything, the differential things and everything. All right. So, that's like a brief summary. So, let's go back to our question. We have 1-month-old baby. Age is very important. Coming with purulent eye discharge. There was mild eye redness. What is the causative organism? So now you have these two STIs, chlamydia and gonorrhea, and you have streptococcal, which is a bacteria. Okay, let me go through the chat box to see. Okay, my question actually, I was going to ask what Dr. Shabir has asked. That's why I wanted to go through the chat box to see what you all have answered. Okay, only few of you have selected answer C. Why not streptococcal? I'm asking the same question as Dr. Shabir asked. I'll tell the answer, but let me see if any one of you know the answer. Why not bacterial conjunctivitis here? Why not C? Why most of you have gone through A and B? Why not C? Can somebody answer that question? Or if you think C, even you can tell that also. Sore throat. By the symptoms that are given in the history? Fever, one thing, yes. Fever and neonatal sepsis will be there if it is streptococcus. That's also okay. But with the other symptoms that are given, If let's think it's a mild, very good. Dr. Israt, very good. Mild redness is the answer actually. Now here see in a streptococcal or bacterial conjunctivitis, the most prominent thing would be the redness. They will have red, itchy, like burning type of eyes, and this eye discharge will be not very purulent and it will be minimal. So mild eye redness is the one that tells you this is not bacterial conjunctivitis. In bacterial conjunctivitis, you will have full-blown eye redness, not a mild eye redness. So that's the clue that tells you this is not a streptococcal conjunctivitis. Okay, so that's the answer. So this can't be streptococcal. Now, out of chlamydia and gonorrhea, we know gonorrhea presents early. So this can't be gonorrhea. The answer should be chlamydia. Answer A. Did you understand? I think Dr. Shabir was the one who asked that question, right? Okay, so now this ophthalmia neonatarum 1 to 2 week, not 1 month, it can present late as well. It's in the neonate period. So 1 month is valid. It can present early, it can present late also. Okay. Any more questions? No. All right. So let's move on. Still the baby is 1 month, not 1 year. A wife is concerned that husband keeps a lot of things in house. Now no space for her. What to check in the husband? A, mood. B, childhood sexual abuse. C, substance abuse. Okay. Now here again, wife is concerned that husband keeps a lot of things in the house. Now no space for what to check in the husband. Okay. Answer A, mood. B, childhood sexual abuse. C, substance abuse. Okay. Now this is a case of hoarding syndrome, right? Okay. So what do you think? Now here also you have to check, correct, select the answer which is specific for that syndrome. Okay. So whenever you have a diagnosis, whenever you have a disorder, you have to select the one which is specific for that syndrome. Keeping that in mind, what is the answer? A, B or C? Okay. So if you think if the working diagnosis is a hoarding syndrome here, okay, what else are the differential diagnoses? Hoarding syndrome is one. Correct. What else are the other differential diagnoses? Other causes? Schizophrenia. Very good. One thing could be schizophrenia. Why schizophrenia? I think I'm not going to, it's not fair to tell the name and us. Hoarding, how hoarding in schizophrenia? Yes, OCD. How hoarding in OCD? Yes, because they have obsession, but usually OCD in the other way. They are more towards cleaning side. How hoarding in schizophrenia? Delusional. Very good. Because they can have these delusions and control hallucinations and delusions which tells them to keep stuffs. Now this wife is not telling that the husband collects dirt. Nothing as such is given. Wife is concerned that husband keeps a lot of things in the house. We don't know what sort of things he keeps. Nothing is given. But this can be a hoarding syndrome, which is not a very dangerous thing. But this can be a schizophrenia or any other psychotic sort of a syndrome as well. Okay. So, what to check in husband? For hoarding syndrome diagnosis, I'm sorry I couldn't include the DSM-5 criteria here, but when you go through Google and see, you have this criteria. I think there were about 5 or 6 features there. Everything is relevant to the hoarding collection of and this stuff, that stuff like that. Okay, so everything is relevant to the hoarding. But hoarding syndrome itself is not dangerous. But what if it is a schizophrenia or some other psychotic disorder? So here your challenge is to exclude any psychotic disorder from simple hoarding syndrome. So for that, you have to check the mood. So checking the childhood sexual abuse will not help you to come to a diagnosis here. It will tell an etiology, but the childhood sexual abuse is linked more with psychotic and other disorders rather than a hoarding syndrome. Substance abuse can be a comorbidity here that you are going to assess in anybody. But assessing his mood will tell you whether this is a hoarding syndrome or whether this is schizophrenia or whether this is any other psychotic disorder. So mood is the one that you have to assess here. In any psychiatric disorder, assessing the mood is very important. Even this could be a sort of a manic episode when they are like so fond of when they have this high energy period, they are so fond of collecting different memories and stuff and keeping them. So we don't know. So we need to check the mood here. So answer should be answer A. Okay, let's move on. 40 weeks. Again, a labor one. Pregnant woman passed mucus plug containing blood. Fetal movements are normal. No other symptoms. All vitals are normal. No uterine contractions. Head 3 cm above ischial spine. Cervix 2 cm dilated. What to do? A. Wait for spontaneous labor. B. Intravaginal prostaglandin. Previous question, answer A, Dr. Aisha. Mood. Okay, so now let's see. Okay, so here let's go through this case. Again, a labor. Now in labor, we know we have to first see the POA. So this is a 40 week. That means term. This pregnant woman is at term. She passed a mucus plug containing blood. What is this? What is the name for this mucus plug containing blood? Can somebody make show? Very good. This is a show. So this is show. Okay. Fetal movements are normal. No other symptoms. All vitals are normal. So mother and the baby are normal. No uterine contractions yet. Head 3 cm above ischial spine, that is station -3. Cervix 2 cm dilated. What to do? Okay, so cervix is slowly now ripening and it's ripened actually. It's slowly dilating. It's 2 cm dilated. So still no contraction. So she's now going into labor actually. So she's in the early part of the labor. Cervix is now dilating. She has show. So still no contraction. So what are you going to do? Are you going to put intravaginal prostaglandin or wait for spontaneous labor? Now here again, we are going to, whenever you have a labor question, you are going to see whether the mother or baby has any problems. Now here everything is normal, no meconium, nothing, everything is stable. So you don't need to, now in labor questions, you have to always select two options, whether you are going to go for urgent delivery or whether you are going to deliver later slowly. If you are selecting the option 2, deliver later slowly, then you are going to select whether you are going to induce to augment the labor or you are going to allow the natural labor to progress. Now here there's no indication for you to go for an urgent delivery. So anyway, answer C, the cesarean section is not there. But even if it was there, you are not going to select that. But then the problem is between whether you are going to let the spontaneous labor to occur or whether you are going to put vaginal prostaglandin. That depends. Again, the fetus and mother are stable, no problem. So you don't need to rush things. But see the POA. POA is 40 weeks. For how long, until how long can you wait? Like according to guidelines? 42, yes. You can wait up until 42 weeks. According to the guidelines, you can wait up until 42 weeks for a natural labor to occur, for spontaneous labor to occur. Now, here, see, she has partial, cervix is slowly dilating. So, why are you going to rush things? You can wait for some time. You are not going to wait forever. So, you can wait for the spontaneous labor here because it's still 40 weeks. If this was 43 or 40, no, you are not going to anyway wait for 43. 42 also, then you can rush things. But here it's still 40, so you can wait for spontaneous labor. So answer would be answer A. Okay. All right. Let's do one more. No, we can do, I think. Let's see. Stable patient at first came for subclavian catheter placement, developed respiratory distress, engorged vein, resonant percussion, severe distress. Next. A. Large bore cannula thoracotomy. B. Intubation. C. Needle decompression. Okay, so this is a very easy one, right? All of you have correctly answered. Yes, this is a case of iatrogenic pneumothorax. Why? When put in the subclavian catheter, I think they have punctured the pleura. So developed respiratory distress, engorged veins, and resonant percussion. So you are going to do needle decompression. Answer C. That's self-explanatory, right? You don't need to discuss it a lot. Answer C. Any? Okay, now Bishop explanation. I think you will have a class on that. We'll see. If we have time, I'll explain. It will take some time. Bishop actually is a score that, how can we tell simply? So you have different parameters in Bishop score. For example, you have like the parameters would be you are checking the cervical dilatation, you are checking the position of the cervix, then the station, then cervical consistency and the effacement and everything. Okay. And it's like a score that we use to assess, to predict whether we need to induce the labor or not. So you are, as I told, there are multiple parameters and you are getting a score based on the multiple parameters. And based on the score, you are checking whether you need to induce the labor or not. Okay. So what is the cutoff for induction in Bishop? Can somebody mention? 5, yes. If it is 5 or 6 actually, if it is less than 6, if it is less than 6, then you take that the labor will not start spontaneously and you are inducing it. If it is more than 6, then you think you are taking that labor will proceed and you are not going to induce it, something like that. So it's a collection of, in simple term, it's a collection of factors. If you can Google and see if you the criteria. I can't remember the levels, but there are about 6 features which I told, like the cervical dilatation, position, then the station, effacement, and consistencies, and you have score for each feature from 0 to 3. And then you are calculating the total score, and if it is less than 6, you say the labor is unlikely to proceed naturally. So you are going to induce it. If it is more than 6, you think it is proceeding naturally and you are not inducing it. Something like that. So it's a pre-labor score actually. Did you understand it now? The person who asked, did you understand it now? Okay, I think here you have the table. Somebody has shared the table. Yes, I told them correctly. You have these features and the values. Okay, so you can go through that table also. So in summary, that's what the thing is what I told. Understood, right? Okay, when do we call Dr. Faizia? Usually, if the bishop ripened is like it's used like not a very, it's a bit of a late term, not a very technological term. So here I use the word because the cervix is dilating. But the optimal cervix would be when the bishop is equal to more than 6. Okay. So don't go by that term itself, you go by that. Okay, did you understand? All right. You can search bishop score in the Google and you can get it. Now it's the modified bishops. Anyway, those criteria are there. Next question. Is iatrogenic pneumothorax secondary pneumothorax which requires ICD as per notes given? No, in pneumothorax, you are not going to put ICD as the first. In pneumothorax, you are going to put needle decompression. You are going to put a wide bore needle or cannula in the second intercostal space and you are going to decompress it. Okay, so that is needle decompression in pneumothorax. But that is specifically tension pneumothorax. You are not going to put the needle and decompress each and every pneumothorax. If it is a small secondary pneumothorax or a small thin rim of air or small pneumothorax, you are not going to put the cannula and decompress it. If it's a tension pneumothorax, you are doing this. Now here, this is a tension pneumothorax. Why? You have respiratory distress, engorged vein, resonant percussion, everything, and severe distress. So this is a tension pneumothorax. So you will have to reduce the tension or decompressing it. For small pneumothorax, you have a separate way of managing them depending on the pneumothorax level, actually, the thickness of the fluid around the pleura and those things, you are going to manage them separately. Those are secondary pneumothoraxes, actually. So that's a separate topic. For tension only, you are doing this. Okay. Did you understand the one who asked? Ma'am, that is for primary, yes. Primary is the small ones. You are going to manage like that. This is a traumatic pneumothorax, iatrogenic pneumothorax, both are same. Iatrogenic mean induced by us. Okay. Okay. Do you, I think, all right, we have already passed the finishing time. If secondary and large but asymptomatic, we will observe a needle. If it is a tension pneumothorax, you are decompressing it with needle. For other small pneumothorax, you have a separate way of managing that is a separate topic actually. If no tension, you don't need to needle decompress. All right. Okay, no more questions. I don't think we have time to continue with the next questions. So let's stop the session for today. And we'll continue with the rest of the questions in the next session. We'll have some more sessions in this month. All right. So I hope I answered all of your questions. Thank you very much for joining today and for your interactive participation. We'll meet again in another session. Thank you. Have a nice day and good night.